Good morning. Really glad you guys could join us this morning. I'm Ray Walker. I'm the Divisional Director for the Medicare Assistance Program at the Oklahoma Insurance Department. Thank you for joining us for this next webinar in our series, Getting Ready for Open Enrollment. Wanted to remind you, I know you've heard me say this before, open enrollment is going on right now. It will go until December 7th. So we really want people to take advantage of this opportunity to review your current coverage, whether that's your health coverage, your drug coverage. Allow us the opportunity to help you compare what's available to you. Possibly there's something out there that could save you some money or give you some better coverage on your medications or something. So doesn't cost anything. We are not selling any products. All we're going to do is give you the information so that you can make the best decision for yourself. We don't sell anything. So again, our phone number is 800-763-2828. And there's someone that answers that phone 24 hours a day, 7 days a week. So take advantage of that opportunity. Also wanted to remind you, this isn't the last webinar. Next week on November 3rd, we're going to have one on Medicare supplement policies. So today we're talking about Medicare Advantage plans. Next week we'll talk about Medicare supplement plans. And then the following week on November 11th, Jose Olivero from the Social Security Administration is going to join us. And he's going to be telling us about some updates there and where you can go to get answers regarding your Social Security. And then something new this year, we are going to have on November 17th, we're going to have a Welcome to Medicare event, and it's going to be in Spanish. So that's going to be something new. Please, if you've got somebody you know that, maybe English is a second language for them and they would benefit from having this webinar, we are going to have this webinar completely in Spanish, and that's going to be on November 17th. So please pass the word around. So wanted to remind you, we are recording these events. So if you do miss one or you know someone that might benefit from the information, they can go to the same website where you registered for this event. Just go to oid.ok.gov and go to the screen where you register, and you'll notice next to each one of the webinars, there's a button where you can listen to the recording. So take advantage of that and listen to those webinars if by chance you missed one in the past. So before we get started, I also wanted to remind you, we're not going to actually take live questions as far as people talking during the webinar, but if you do have a question at any point in time during the presentation, down in the lower right corner of your screen, you're going to see a box that says chat. Feel free to type in your questions in that box, and when we're done with the presentation, we'll circle back around and we'll go through each one of those questions. So do take advantage of that. If you don't understand something, if you're not clear on something, put that information in there and we'll make sure that we get you an answer. So moving right along, I want to introduce our speaker for today. Her name is Angela Cain. Angela started working at CMS in 1988 in Baltimore, which is like the central office for CMS. So she started in 1988, so clearly she was around 3 years old. She graduated from the University of Baltimore with a Bachelor of Science in Health System Management. And in October of 2020, she realized a little bit earlier, this is her 1-year anniversary today. She joined the Office of Program Operations and Local Engagement in the regional office for Region 6 in Dallas for CMS. If you're curious, Region 6 includes Texas, Oklahoma, Louisiana, Arkansas, and New Mexico. And once a month, Angela heads up a meeting where we get all of these different regions together, and she tries to get us to get updates and give information and stuff, which is a little bit like herding cats, and I can't imagine how difficult that would be for a person. But then she shared with us earlier that she actually has 4 sons. So now I understand why she's able to keep us coordinated and working together. So Angela, thank you so much for joining us today, and we look forward to hearing what you have to share.
Thank you, Ray. That was very nice. Hello, everyone. I am so happy to be here. I will be sharing with you, talking about Medicare Advantage plans. And I would like to open my slides and share my screen just briefly. And then I will open the slide show for you. Okay. So we will be, thank you for going on a journey to overview what Medicare Advantage plans are, how they work, and how a person with Medicare can join or switch a plan and compare them to other plans. Then, as a bonus, we will go over some of CMS's communications and marketing guidelines. Medicare Advantage Plans, Part C. They are Medicare approved companies that offer an alternative to original Medicare for health and drug coverage to people with Medicare. They are plans that are bundled to include original Medicare's Part A for hospital insurance, Part B for medical insurance, and usually Part D for prescription drug coverage. MA plans are also known as Part C. You'll notice the first four letters of the alphabet are used to help categorize Medicare plans more easily: A, B, C, and D. And as my colleague Carmen Irwin likes to refer to it as the alphabet soup. The private companies that offer MA plans, Medicare Advantage plans, must follow rules set by Medicare and are required to cover everything that original Medicare covers. MA plans usually use healthcare providers who participate in their plan's network, although some plans offer out-of-network coverage. People with an MA plan still have Medicare, but they'll get their their Part A and Part B coverage from the MA plan instead of original Medicare. MA plans may provide an enrollee with an ID card to get healthcare services and supplies. However, the provider may also ask for the original Medicare card too, so enrollees should keep that card handy as well. How do Medicare Advantage plans work? MA plan enrollees have all rights and protections covered by Medicare. They must have both Part A and Part B to join an MA plan. They may choose a plan that includes drug coverage and can be charged different out-of-pocket costs. They cannot be charged more than original Medicare for certain services. They may choose a plan that includes extra benefits at the plan's expense, not covered by Medicare, and they may have a yearly limit on their out-of-pocket costs. Additionally, MA plans can cover more extra benefits than they have in the past, including services like transportation to doctor visits, over-the-counter drugs, adult daycare services, and other services that promote health and wellness. The benefit must focus directly on an enrollee's healthcare needs and be recommended by a licensed medical professional as part of a care plan in order for CMS to approve it. Every MA plan has a service area that an enrollee must live in. Enrollees or their provider can get an organization determination to find out whether an item or service is covered by the plan in advance. This is a requirement for some services. The companies offering MA plans receive a fixed amount for coverages each month. Each MA plan can change different out-of-pocket costs and have different rules for how an enrollee receives services, like whether they need a referral to see a specialist or a provider within the plan's network for non-emergency or non-urgent care. The rules can change each year. Hospice care is covered for a beneficiary who is enrolled in an MA plan, but it's covered by original Medicare. So we have different types of Medicare Advantage plans. For the purposes of this shortened presentation, I will review the Health Maintenance Organization, HMO, the Preferred Provider Organization, PPO, and the Special Needs Plan, SNPs. In a Medicare Health Maintenance Organization, HMO plan, a beneficiary generally must get their care and services from within the plan's network, with some exceptions such as emergency care, out-of-area urgent care, or temporary out-of-area dialysis. In most cases, prescription drugs are covered as long as the beneficiary joins an HMO plan that offers drug coverage. Also, in most cases, a beneficiary would need to choose a primary care doctor and get a referral to see a specialist. Sometimes a doctor may believe the best treatment for a condition should be obtained out of network, and may refer the beneficiary outside the network. In this case, the provider should request a written pre-service organization determination from the plan, allowing the beneficiary to only pay plan cost sharing. Beneficiaries or people with Medicare should also know their MA plan will notify them if their doctor or other healthcare provider leaves the plan's network, and that they can choose another doctor in the plan's network. They may have to pay full costs if they obtain healthcare outside the plan's network. And they should also know that it's important to follow the plan's rules, like getting prior approval for a certain service when needed. In a Medicare Preferred Provider Organization, PPO plan, enrollees have a network of providers they can use, or for a higher cost, they can use out-of-network providers for covered services. In most cases, prescription drugs are covered if the enrollee joins a PPO plan that offers drug coverage. If they don't, they can't join a separate Medicare drug plan. And that's very important to know. Enrollees don't need to choose a primary care doctor, and in most cases, they don't have to get a referral for a specialist. If they use plan specialists in network, their costs for covered services will usually be lower than using non-plan specialists who are out of network. Enrollees should be aware that a PPO is different than original Medicare or Medicare supplemental insurance, also known as Medigap. PPO plans usually offer more benefits than original Medicare and may cost extra. There are two kinds of PPO plans: regional preferred provider organization plans that serve one of 26 regions decided by Medicare. They may be a single state or multi-state area. And then there's the local preferred provider organization plans that serve the counties the PPO plan chooses to include in its service area. A special needs plan, SMP, provides benefits and services to people with specific diseases, certain healthcare needs, or limited incomes. SMPs tailor their benefits, provider choices, and lists of drugs or formularies to best meet the specific needs of the groups they serve. The beneficiary generally must get their care and services from doctors, other healthcare providers, or hospitals in the plan's network, except emergency care, out-of-area urgent care, or out-of-area dialysis. All SMPs must provide Medicare drug coverage, or Part D. Beneficiaries generally need to choose a primary care doctor. In most cases, they need a referral to see a specialist. Medicare SMPs are MA plans that limit membership to enrollees with specific diseases or characteristics, as I mentioned earlier. An enrollee is eligible to enroll in an SMP if they live in certain institutions like nursing homes or require nursing care at home, also known as institutional SMP or I-SMP. They're eligible for both Medicare and Medicaid, also known as a dual eligible SMP or D-SNP. D-SNPs will contract with their state Medicaid program to help coordinate their Medicare and Medicaid benefits. Or they have specific severe or disabling chronic conditions like diabetes, end-stage renal disease, ESRD. Also called a chronic condition SMP or CSMP. Plans may also further limit membership. Okay, the plan finder has limitations with D-SNPs or dual SNPs, such as having the ability to filter for D-SNPs that include long-term care coverage from other types of SNPs. It also has difficulty explaining available plans apart or understanding differences in what each plan covers, and it does not include plan eligibility requirements. On September 3rd, we pulled a report of the SMP service organization providers for dual eligible and or chronic or disabling condition in our Region 6 area. So for Texas, there are 29. Oklahoma has 6. New Mexico has 4. Arkansas has 8. And Louisiana has 9. When can a person enroll in Medicare Advantage, in a Medicare Advantage plan? A person with Medicare can join an MA plan when they first become eligible for Medicare, generally during their initial enrollment period, or IEP. If they have Part A and enroll in Part B during a general enrollment period, or GEP, they can enroll in an MA plan between April 1st to June 30th. As you can see, there are certain situations that would qualify a person with Medicare to a special enrollment period, or SEP. Each year from December 8th to November 30th, a person with Medicare can switch to an MA plan or Medicare cost plan that has 5 stars for its overall star rating. The 5-star SEP can be used only once in a time frame. A person with Medicare has the opportunity to review their Medicare coverage and join, switch, or drop their plan during the yearly OEP, open enrollment period, that has already started this year and ends on December 7th. Their coverage would begin on January 1st, as long as the plan receives the request by December 7th. The MA, the MA Medicare Advantage or open enrollment period allows people with Medicare enrolled in an MA plan to make a one-time change during the first 3 months of the calendar year, January 1st through March 31st, to switch MA plans or to drop an MA plan and get coverage through Original Medicare or trial right. This includes those who may have joined anytime during the first 3 months. Coverage begins the first month of the following enrollment. Additionally, if a person with Medicare enrolled in an MA plan during their initial enrollment period, IEP, they can make a change within the first 3 months of their Medicare coverage. Note, if a beneficiary drops a Medicare supplement insurance or Medigap policy to join an MA plan, they might not be able to get it back. Rules can vary by state and their situation. And Medicare supplement insurance is an additional coverage that would take care of things like the deductible or co-payment, things that Medicare doesn't cover, because Medicare actually covers 80%, and beneficiaries are required to pay for the 20% left over. Changes to Part D coverage are limited for people with Medicare who use the MA open enrollment period. Enrollees who use the MA open enrollment period to make changes to their MA coverage may also enroll in or disenroll from Part D coverage. For example, if they're enrolled in an MA plan with drug coverage, they may use the MA OEP, open enrollment period, to switch to 1, another MA plan with drug coverage, 2, an MA only plan, 3, an MA only private fee-for-service plan with or without a standalone Part D or prescription drug plan, or 4, Original Medicare with or without a Medicare drug plan. The MA OEP will also allow people enrolled in an MA only plan to make a switch. Not all MA plans work the same way. The MA enrollees should understand the plan's rules and costs. They can do that by searching for health and drug plans at medicare.gov/plan-compare or call 1-800-MEDICARE, 1-800-633-4227. All plans must offer the option of providing enrollment forms to be completed and returned to the plan. Also note, Medicare plans aren't allowed to call a person with Medicare to enroll them in a plan. unless they specifically ask to be called. Also, plans should never ask a beneficiary for financial information, including credit card or bank account numbers over the phone. Things a potential enrollee should consider before joining an MA plan include whether they have Part A and Part B. Does the plan offer extra benefits, and is there an extra cost? Would they be required to use the plan's network or need a referral to see a specialist? Whether they can manage a Part B premium and usually a monthly plan premium. They need to be aware that they can only join or leave the plan during certain periods, and that they would not be able to have a Medigap or supplemental policy while in an MA Medicare Advantage plan. Can a person with Medicare and end-stage renal disease join an MA plan? Yes, they can enroll in an MA plan or an MA plan with drug coverage during this season, this open enrollment season, for coverage that will start January 1st, 2022. This chart displays a side-by-side comparison of Medigap with MA plan policies. Both are offered by private companies. Medigap must follow federal and state laws, but routine day-to-day oversight of standardized Medigap policies is the state's responsibility. MA plans must be approved by Medicare. Medigap policies only work with Original Medicare. Original Medicare pays for many, but not all, healthcare services and supplies. Private insurance companies sell Medigap policies to help pay for some of the out-of-pocket costs or gaps that Original Medicare doesn't cover, as I mentioned earlier. Medigap policies don't pay Medicare premiums. Most Medigap policies don't cover out-of-pocket drug expenses. A beneficiary must have Part A and Part B to buy a Medigap policy. A person with Medicare would have to pay a premium for a Medigap policy or an MA plan, as well as the Part B premium with both. It's illegal for anyone to sell a beneficiary with an MA plan a Medigap policy unless they are disenrolling from the MA plan to go back to Original Medicare. There are other types of Medicare health plans that provide Part A and Part B, while others provide only Part B coverage. In addition, some also provide Part D drug coverage. These plans have the same rules as MA plans, Medicare Advantage plans. However, each type has special rules and exceptions. Medicare cost plans are a type of Medicare health plan that's available in certain limited areas of the country. A person with Medicare can join even if they only have Part B. If they have Part A and Part B and go to a non-network provider, the services are covered under Original Medicare. They'll pay the Part A and Part B coinsurance and deductibles. Programs of All-Inclusive Care for the Elderly, or PACE, is a Medicare and Medicaid program offered in many states that allows people with Medicare who otherwise need a nursing home level of care to remain in the community. To qualify for PACE, a person with Medicare must meet certain conditions. PACE covers all Medicare and Medicaid covered care and services and other services that the PACE team of healthcare professionals decides are necessary to improve and maintain the beneficiary's health. If the person with Medicare has Medicaid, they won't have to pay a monthly premium for the long-term care portion of the PACE benefit. There's a deductible or copayment for any prescription drug, service, or care approved by the PACE team of healthcare professionals. You can visit medicare.gov/plan-compare/pound /PACE, PACE, to see if there's a PACE organization that serves your community. Now we're at a fun part called Check Your Knowledge, and you can participate if you feel that you know the answer, and hopefully you do. First question of the slide. Well, this may be the only question for this section. Medicare Advantage plans, A, help pay for gaps in original Medicare. B, must keep the same providers all year. C, are private plans approved by each state? Or D, must cover all Part A and Part B covered services? You can put your answers in the chat, and I'll give you a few seconds. Okay. We're getting some answers. Very good.
Yeah, we're getting quite a few D's.
All right, let's see. And D is correct. Must cover all Part A and Part B services. They offer all Part A and Part B covered services, but may cover additional benefits not covered by original Medicare, like vision and dental. Their cost sharing may be different than that of original Medicare, and they are run by private companies, but they must be approved by Medicare. Thank you for participating. So next we will go over Medicare communications and marketing guidelines. Do we need a break, or am I good to go through?
There were a couple of questions that popped up, and so we're doing great on time. So let's go ahead. One had to do when you were talking about the D-SNPS and long-term care coverage.
Okay.
And I think that they were just a little, maybe we went too quickly through it. So can a D-SNP actually cover long-term care?
Yes. What did it say? It said that there was a limitation. Let's see.
It's quite a few slides back. I'm trying to remember where it was at.
Okay. Plan Finder, D-SNPS. Okay. Long-term care. Where did I talk about long-term care? And I'm sorry I don't know this, but I will definitely look into it and get more information about it. But I do recall mentioning, let me see if we can go back one more. No, that's PPO. Okay. The long-term care. Oh, it was related to if you're on Medicaid, you wouldn't have to pay for long-term care. But so I think it does. It sounds like it does provide long-term care, but the person would have to pay for it. You know.
I see. So it's probably just saying if you've got Medicaid, which typically is what pays for long-term care, you're allowed to be enrolled in a D-SNP. So awesome. The other question that came up, and this is probably not a fair question for you, but it is a question that comes up from time to time. Why do Medigap plans not cover Part D?
Yeah, I don't know. And I can look into it more and see if I can get answers. You said why don't Medigap cover Part D?
Yeah, I know a few of the older Medigap policies did have a prescription drug benefit like Plan J did, but it was nowhere near what is considered creditable coverage by today's standards, and those plans are no longer available. So yeah, I'm curious too. And then we had another question.
Awesome. Yes.
As a general rule, what coverage pays the most benefits, original Medicare A, B, and D, or a standalone MA plan with prescription drug coverage?
I think it depends on which plan you choose. Yeah, it depends. Yeah, on the plan, because the plans offer different types of coverages. Yeah, but let me take that back and I will follow up on that question as well. Would you be able to send me those questions?
You bet.
Okay, thank you, Ray.
Last question. Does
Mm-hmm.
the Affordable Care Act website
Mm-hmm.
include Medicare Advantage? Hang on just a second, my screen moved. Does the Affordable Care Act website include Medicare Advantage plans for comparison and enrollment?
Yes. Yep, absolutely. And I will be showing you some comparisons, and we have appendices at the end of this presentation that I will show you some comparisons. So yeah, and I'm sure the Medicare Advantage website would
Okay.
show them as well.
And this next one kind of feeds into what you were just saying as far as what you're going to share. The question
Mhm.
is, how do you choose? There are so many options. So it sounds like we're going to get into that here shortly.
Yes, absolutely. Basically, a person would have to be aware of what their needs are, and then review all of the options, and then choose the one that's best for them, that fits them. Look at their budget, look at their health, and understand what they need, like the drugs or services they may need to have a healthy life. Um, so they need to be able to consider everything that they need, and then look at all of the different plan options, and then compare it to their budget. Yeah, basically. Just
Okay.
like we do
One
when
one last question, and then
working.
we need to move on into your next part. If
Okay.
I switch to an M, and I believe you did cover this.
Hmm.
Uh, if I switch to an MA plan, can I renew my Medigap policy in place? So I'm thinking what they're saying is if I decide to try an MA plan, can I get my Medigap policy back later if I don't like it?
Uh, I thought, well, they would have to go back to original Medicare in order to get the Medigap plan. And there was a slide on that, and I mentioned it twice that there is something. I'll look that up again, but there is a case where you would not be able to get the Medigap plan back, and I think if it's
I know that typically the way that it works is if someone is on a Medicare supplement policy and they
mhm.
decide for the first time they want to try a Medicare Advantage plan, they can do so. And if within the first 12 months they decide they didn't like it and they want to go back to the MedSup policy they had before, they can do that. Now, if that
Okay.
MedSup policy is no longer available for whatever reason, it's not sold anymore, then they
Mhm.
would have an option of a few other plans. So I know that's the way it's always been before.
Okay, and you're right about the 12 months. You're right, absolutely. Thank you,
Yeah,
Ray.
I got a star. Okay, go
Yes.
ahead.
Okay. So, in this lesson, we will go over, so that we're going over the Medicare communications and marketing guidelines. We're going to cover things like reminders, marketing reminders, um, unsolicited enrollee contact, cross-selling prohibition, and educational rules and regulations for agents and brokers to make, we want the consumers and to be aware of. We don't want anyone to be taken advantage of. Okay, communication and marketing materials. Um, the Medicare Communications and Marketing Guidelines, MCMG, defines communications as activities and use of materials to provide information to current and prospective enrollees and to influence their decision-making process when selecting a plan for enrollment or deciding to stay enrolled in a plan, also known as retention-based marketing. CMS requires the review and approval of certain marketing materials. Some examples of excluded materials are certain member newsletters, press releases, blank letterhead, privacy notices, ad hoc materials. That's defined in Appendix 1 of the MCMG, which I will be giving you the website to the MCMG at the end of this presentation. Certain marketing materials don't need to be reviewed and approved, but must still be maintained and made available at CMS's request. Medicare health and drug plans must use standardized marketing material language and format without modification, except where specified by CMS. For example, standardized documents include, but are not limited to, the Plan Annual Notice of Change, ANOC, and the Evidence of Coverage, EOC. Plans cannot start marketing for the upcoming plan year before October 1st. Plans must stop current year marketing activities to existing people with Medicare once they begin marketing plan benefits for the new contract year. However, plans may market to individuals eligible for a valid enrollment period, like if they are turning 65 or qualify for a special enrollment period. CMS assigns star ratings to MA plans, Medicare Advantage plans, MA plans with drug coverage, and MA drug plans Part D each year. Performance measurements are used to determine CMS's overall star rating for each plan. When referencing a plan's star rating in marketing materials, individual star rating measures must also include references to the plan's highest rating, overall rating for MA plan with drug coverage, its Part C summary rating for MA plan, or its Part D summary rating with equal or greater prominence. Plans that are assigned a low performance icon, LPI, may not try to refute or discredit their LPI status by showcasing a higher overall star rating on another contract. Excuse me. By showcasing a higher overall star rating on another contract or specific measure star rating. They may not try to refute or discredit their LPI status. Any communications in reference to the LPS must state what the status means. Please note that a contract that gets less than 3 stars for its MA plan or MA plan with drug coverage or Part D overall rating for at least the last 3 years will be marked with the LPI or on medicare.gov/plan-compare. To make sure enrollees get complete plan information regarding their healthcare options, CMS requires MA plans and drug plans to disclose certain plan information, both at the time of enrollment and at least annually. The MCMG, Section 100.2.1, states that without prior beneficiary authorization, health and drug plans may send new and current enrollees a notice or notices informing them how to view the CMS required materials online instead of receiving copies of mail. They must also tell them how to request a hard copy. These notices must be sent in time for an enrollee to receive them by October 15th of each year, but no earlier than September 1st. Additionally, health and drug plans can provide any materials in different media type. Excuse me. Plans must get prior consent from the enrollee. Specify both the media type and the specific materials. Provide a way for enrollees to opt out to get hard copies and ensure other listed criteria are met. For example, we don't have any examples here. Plans are expected to provide required documents for new enrollees no later than 10 calendar days after getting CMS's confirmation of enrollment, or by the last day of the month before the effective date, whichever is later. Here we can see CMS's requirements on how plans communicate the annual notice of change, ANOC, and evidence of coverage, EOC, to their members. Both notices have to be distributed by certain due dates. Health and drug plans may offer nominal gifts up to $15 with a maximum of $75 per year to potential enrollees for marketing purposes, as long as the gift is given regardless of whether they enroll and without discrimination. You can refer to the Office of Inspector General's website regarding advisory opinions on gifts and gift cards. Medicare health and drug plans may make unsolicited and direct contact with potential enrollees using conventional mail and email with an opt-out function. Health and drug plans may not use door-to-door solicitation, including leaving information such as a leaflet or flyer at a residence. They may not approach potential enrollees in common areas like parking lots, hallways, lobbies, sidewalks, etc. They may not use telephonic solicitation, including text messages and leaving electronic voicemail messages. But note, agents and brokers who have a pre-scheduled appointment with a potential enrollee who's a no-show may leave information at that potential enrollee's residence. Plans may also make outbound calls to existing members to conduct normal business related to enrollment in the plan. Call people with Medicare who submit enrollment applications to conduct business related to enrollment. They may call former members after the disenrollment effective date to conduct a disenrollment survey for quality improvement purposes. They, under limited circumstances with CMS approval, call low-income subsidy eligible enrollees who are being assigned to encourage them to remain enrolled in their current plan. They may contact people with Medicare who have given permission for a plan or sales agent to contact them, like completing a business reply card. And they may return phone calls or messages from individuals or enrollees, as these are not considered unsolicited contacts. CMS prohibits cross-selling, which is marketing health care related products such as annuities and life insurance to prospective enrollees during any MA plan or Medicare drug coverage sales activity or presentation. People with Medicare already face difficult decisions regarding Medicare coverage options and should be able to focus on Medicare options without confusion. Plans should not imply that the health and the non-health products are a package. Plans may sell non-health related products on inbound calls when a person with Medicare requests information on other non-health related products. Marketing to current plan members of non-MA plan covered healthcare products and or non-healthcare products is subject to the Health Insurance Portability and Accountability Act, known as HIPAA rules. The MCMG requires marketing representatives to clearly identify the types of products they will discuss before marketing to a potential enrollee. Marketing representatives who initially meet with a person with Medicare to discuss specific lines of plan business, separate lines of business include MA plan, Medicare drug plan, and cost plans, must tell the person with Medicare about all products they will discuss before the appointment, so that they have accurate information to make an informed decision about their Medicare coverage choices without pressure. Before a telephone or in-home marketing appointment, the person with Medicare must agree to the scope of the appointment. The plan can document the scope of the appointment in writing or telephone recording. Organizations may not discuss additional products unless the person with Medicare requests the information And any additional lines of plan business that aren't identified before the in-home appointment will require a separate scope of appointment authorization form to be completed or recorded. Again, products that aren't health related may not be discussed, such as annuities or life insurance. Medicare health and drug plans may not give prospective enrollees meals or subsidized meals at sales events or any meeting at which they discuss plan benefits and or hand out plan materials. Agents and brokers are allowed to provide refreshments and light snacks to prospective enrollees. Plans must use their best judgment to ensure they aren't bundling and providing multiple items as if they are a meal. It's the responsibility of the plan to monitor the actions of all agents selling their plans and take proactive steps to enforce this prohibition. CMS conducts oversight activities that verify plans and agents are complying with this provision and can take enforcement actions as needed. Educational events are designed to inform people with Medicare about MA plans, Medicare drug coverage, or other Medicare programs. They must be explicitly advertised as educational. Contact information may be given to people with Medicare, and marketing or sales activities or distribution of marketing materials or enrollment forms must not occur during the educational event, but can be done immediately afterwards. Marketing or sales events are designed to steer or attempt to steer potential enrollees or the retention of current enrollees toward a plan or limited set of plans. Here you can see a list of the requirements plans and their agents or brokers must meet that apply to all marketing sales events. Health and drug plans that conduct marketing through agents, brokers, and other marketing representatives must comply with state licensure and appointment laws to give the state information about which agents are marketing MA plans and drug plans. Unless required by law, some activities carried out by the plan's customer service representatives don't require the use of the state licensed marketing representatives. Those activities include providing factual information, fulfilling a request for materials, or taking demographic information to complete an enrollment application at the initiative of the prospective enrollee. There's a process for health and drug plans and reporting termination of any agents or brokers to the states if required. In addition, any for-cause terminations, meaning specific legal or organizational policy violations that made it necessary to terminate employment, must be reported to the CMS account manager by email or letter. Health and drug plans must ensure that agents and brokers selling Medicare products are trained and tested annually on Medicare rules and regulations. I will repeat this because it may be on a test your knowledge question. Health and drug plans must ensure that agents and brokers selling Medicare products are trained and tested annually on Medicare rules and regulations and on plan details specific to the plan products they're selling. This requirement applies to all agents and brokers. They must pass a test with a score of 85% before marketing products. Medicare Advantage plans and MA plans may include information about rewards and incentive programs in marketing materials for potential enrollees, but they can't be used in exchange for enrollment and must be provided to all potential enrollees without discrimination. Medicare drug plans are not permitted to develop or use rewards and incentive programs, so they are not allowed to market them. Medicare drug plans are not allowed to market rewards and incentives. Okay, we are at a part that you can participate in. Check your knowledge. Question 1 for this section. Who's responsible for training and testing agents and brokers about Medicare and proper marketing of Medicare products? Is it A, insurance associations? B, Medicare Health and Drug Plans? C, the Centers for Medicare and Medicaid Services, CMS? Or D, State Department of Insurance? Please put your answers in the chat.
Let's see, so far I'm seeing the insurance department. That's the only response I'm getting so far.
Okay.
Somebody said B.
Okay. Evelyn?
Another person said C.
Okay. Patrick? All right, let's see what the answer is. It's B. Yay! Medicare Health and Drug Plans are responsible. Medicare Advantage Plans and Medicare Drug Plans must ensure that agents and brokers selling Medicare products are trained and tested annually. So the plans, the health insurance plans, are responsible. Training and testing should be on Medicare rules and regulations and on plan details specific to the plan products being sold by the brokers and agents. Training and testing must be completed by passing a test with a score of 85%. CMS releases information each year to all Medicare health and drug plans that specify what information should be covered in training and testing curricula. So CMS does coordinate with the health plans on this. So thank you for participating. We have one more question. Agents or brokers are permitted to set up individual marketing appointments at educational events. Is it true or is it false? And you can put your answers in the chat.
Got an A. Got another A.
Awesome. And the answer is, yeah, you are correct. True. Educational events are designed to inform people with Medicare about Medicare Advantage plans, Medicare drug plans, or other programs. They must be explicitly advertised as educational, may set up a future marketing appointment, and provide business cards and contact information for people with Medicare. And must not include marketing or sales activities or distribution of marketing materials or enrollment forms during the educational event. Plans may conduct marketing or sales events immediately following an educational event in the same general location, like the same hotel. Thank you very much for participating. And that we have come to the end of my presentation, of our presentation. We have a slide here with resources, email, websites, and for CMS, Social Security, Railroad Retirement Board, the MCMG, Medicare Communications and Marketing Guidelines that I referred to, Medicare Managed Care Manual, and the State Health Insurance Assistance Program. Here we have, this slide shows the names and product numbers of CMS publications, products, along with links to view, download, or order them. Here we have Appendix A, comparing MA plans that show whether there is a monthly premium for each type of plan. This appendix compares MA plans on whether they offer Medicare drug coverage, Part D, for the different types of MA plans. This one shows whether a beneficiary can use any doctor or hospital that accepts Medicare for covered services. This one is showing, comparing MA plans on whether a beneficiary needs a referral from their doctor to see a specialist. And here we have Appendix B, comparing original Medicare with Medicare Advantage plan. for doctor and hospital choices. And another Appendix B, comparing original Medicare with MA for costs. And here, comparing original Medicare with the MA plans on coverages that they cover. And finally, we have Appendix B, comparing original Medicare with MA on foreign travel policies. And thank you very much for your time and attention. I'm so happy to be here with you. And thank you, Ray, for allowing me the time to speak. And I'll hand it back
Thank
to
you
you.
so much. You know, one of the things, we'll give people a couple minutes if they do want to ask any other questions, but when you were talking about the marketing guidelines and stuff, one of the things that we do get a lot of feedback about is we'll have counselors from around the state that call us saying, hey, I had someone call me and say, this guy just showed up at my house and signed me up for this insurance. And, you know, it becomes kind of a who said what first. And do agents, is there some sort of record that they keep that demonstrates that proves that they did in fact set up that appointment ahead of time and they didn't just show up at this person's house unannounced? Is there anywhere that that's recorded or kept track of so that if there are these situations, we can backtrack?
Mm-hmm. There should be, but I will follow up on that and find out for sure. Yeah.
And then another question came in. Somebody said, how are you protected if you travel out of the country?
Yeah, original Medicare does not cover care outside of the U.S. And MA plans don't usually cover care. It says some plans may offer a supplemental benefit that covers emergency and urgently needed services. I'm thinking that you would have to search for a plan that covers out of the country services. Yeah. They're out there. You're going to pay. It's going to be kind of costly.
I've noticed on Plan Finder, you know, now that they're allowing them to have more extra benefits, I've noticed that one of those extra benefits that they list over to the right has been foreign travel emergency. It doesn't say how much, but it's got to check that, yeah, they may have foreign travel emergency. So, okay. Yeah. There are some MedSup policies that offer foreign travel emergency. So, okay, we are out of time. Thank you, Angela, so much for joining us.
You're welcome.
I want to remind everybody, we've got a webinar next week where we're going to talk about Medicare supplement policies. We hope you can join us. If you have not registered for that event, please go to our website, oid.ok.gov, and you can register for it just like you did for this one. Also, if you have any questions about Medicare, open enrollment, whatever the case may be, please give us a call at 1-800-763-2828. And we'd be happy to help you. Also, if you'd rather, you can use our email address. You can email Matt, M-A-P, at oid.ok.gov. Some people just prefer to communicate via email. It's, you know, maybe it's harder to hear over the phones or whatever the case may be. We're happy to answer your questions from there as well. So thank you again for joining us, and we hope to see you next week. Thanks.